Happy New Year, everyone.
A very good evening and a very happy new year. Warm welcome to the first episode of ISCCP monthly webinar of 2026. I'm honored to have such senior faculty like Dr. Partha Basu, Dr. Sharda Jain ma'am, Dr. Veena Acharya, Dr. Sarita Shamsundar, and Dr. Leela for gracing this session. Today's topic is cervical screening in vaccination era. HPV vaccination, as we all know, is gaining momentum, and these vaccinated girls are soon reaching the age where screening is crucial. My special thanks to Dr. Partha sir for mentoring me to choose this topic and also to speak on this topic. Thank you so much, sir. Thank you, Dr. Aruna and Dr. Vindhya, to give me this opportunity to conduct this webinar. I will now invite Dr. Aruna Nigam, who's the president of ISCCP, to give a welcome address.
Thank you, Dr. Shweta. So good evening, everyone. A very warm welcome to this monthly ISCCP webinar. It is truly pleasure to see such an enthusiastic participation from colleagues across the country. As we begin this session in a new year, I would like to extend my heartfelt wishes to all of you for a very happy, healthy, and professionally fulfilling new year. May this year bring renewed energy, meaningful learning, and continued collaboration in our shared mission of cervical cancer prevention. ISCCP remains committed to academic excellence and capacity building, and our monthly webinars are an important part of that journey. We have started this from the May onwards, and because of your help, we are able to continue. And in every meeting, we are having more than 100 delegates joining this webinar. Thank you for your continued trust, engagement, and support. I would also like to take this opportunity to invite all of you to our annual ISCCP Con, which is scheduled to be held in Chennai. The brochure we have already circulated. So please register for the conference. You can present your paper and share your views during the conference. It is a beautiful venue in the Adyar. In addition, I would like to announce that the registration for the next batch of the FICCP course and V Insight course is going to start from the 1st of February. As you all know, the fellowship course as well as the vulvovaginal module. Everybody has shown such enthusiastic interest in those courses. So I would like to invite you to register for the next course, which will start from the 1st March. And registration will be open for the 1st of February. You need to be ISCCP member for the same. Besides that, we have already started on the free module on HPV vaccination training, which is freely available on our website. Keep visiting our website, which is always updated, and all the webinars which we conduct are available on our website. I would also like to request all of you, whosoever is involved in the academic and the research, to contribute to our journal, that is a journal of colposcopy and lower genital tract pathology, to contribute in this journal as a research article, review articles, case reports. We will be happy to publish that journal, and it is a peer-reviewed journal. So I will request all of you to submit that your articles. Once again, thank you for being a part of ISCCP. I wish you a highly engaging and academically rewarding webinar. Thank you, Dr. Shweta.
Thank you, Dr. Aruna. Thank you. Now I would invite Dr. Anju Bala. She's the master of today's webinar, and she's the consultant at Sun Permanent Hospital. Over to you, Dr. Anju. Please
Yes,
unmute yourself. Yeah.
Yes, ma'am. Thank you, ma'am. And I welcome everybody here. So we are privileged to be among all the stalwarts today. With this, we start our first session, which is on guidelines for screening of vaccinated women. I would like to invite our chairpersons. Our first chairperson is Dr. Sharda Jain, ma'am. We all know ma'am and ma'am is.
Anju, it's enough. That's it.
I would like to then call Dr. Sarita. Ma'am is Professor Unit Head Gynae Onco VMMC Safdarjung. And next, I would like to invite Dr. Lata Chaturvedula, ma'am. She's professor at Zipmer Pondicherry. And thank you for being here. And ma'am, Dr. Sharda, ma'am, can I request to please invite Dr. Partha Basu, sir?
I think it's a great honor for me to invite Dr. Partha Basu. He does not that we are very fond of him. He is head of a cancer early detection and prevention branch of the International Agency for Research and Cancer based Lyon. He's based at France, and he's a great researcher. And his guidance to all the gynecologists in this particular country is always welcomed. And today he's going to talk on a topic which is very much needed and very basic questions people start asking now. That the people who are vaccinated, what should be their screening policy? So I think, hardly there is any confusion, but at the same time, his wisdom words will definitely enlighten each and every one of us. Thank you very much. Over to you, Dr. Partha Basu.
Thank you. Thank you, Dr. Shada. It's nice to meet you.
Welcome, sir.
Let me share my screen. Can you see my screen? Is it okay?
Yes, sir.
Yes,
Yes, sir.
yes,
We
yes.
can.
Okay. Good evening and very happy New Year to all the those who are attending the webinar. And thank you so much, Dr. Aruna, Dr. Sweta, for having me for this webinar. As you know, the landscape of cervical cancer screening is changing across the world, essentially because of the two reasons. Number one, HPV detection test as the primary screening test is getting momentum because there is a very strong recommendation from the WHO to replace the cytology-based screening or VIA-based screening with HPV detection technology. And second thing is, as Dr. Aruna, Dr. Sweta rightly pointed out, that those girls who received their vaccine when they were in their pre-adolescent age, they are now appearing or arriving at the age when screening starts in different countries at the age of 25 years or 30 years. So we need guidance for these countries, especially like European countries, Australia, and then some of the North American countries that introduced the vaccine way back in 2009, 2010. So their first vaccinated cohort of girls, they are now reaching the age of 30 years when screening should be started. Till now, there is no recommendation from the WHO, no regional recommendation. Only some of the countries they have come up with their recommendations, like Australia, Netherlands. So at IARC, we initiated this particular project, which is to come up with a guidance for the European countries. As you know, the European countries, they almost all of them, they have introduced the HPV vaccine. Here you can see Europe in dark color, and the first cohort of vaccinated girls or women, they are going to appear for screening very soon. So they need this guidance. But then, even in Europe, the situation is very heterogeneous. In every country, there are women who are vaccinated, who are unvaccinated, and more important thing is that most of the European countries, they do not have a vaccination registry connected to the screening registry. So when the women are arriving for screening, there is no reliable way to find out whether that woman is vaccinated or not. So from this perspective, we should, look at it, and then subsequent my presentation is essentially from programmatic perspective, where the program has to decide how they are going to approach screening when there may be some women vaccinated, some women unvaccinated, some women may have received incomplete vaccination. So all these scenarios are there. So with this background, we initiated this project. So, first and foremost thing we need to understand is that vaccination coverage is very important to decide on whether a country should change their recommendation. The first step we did was we came up with a recommendation for unvaccinated population. So the unvaccinated population, the current recommendation for Europe is to screen women starting at the age of 25 years every 5 years with HPV detection test. Now, as I said, there are countries that have, birth cohorts that have been vaccinated, but then there are the vaccination coverage is very variable. So how do we approach this? What we did was we did a meta-analysis of the vaccination impact on HPV 16 and 18 prevalence by their coverage. So if you look at the chart, you see as we go down the chart and the studies like Dillner study in 2018, they reported that if the coverage is 90%, that means very highly vaccinated coverage, in that cohort of girls or women, the HPV 16 and 18 comes to almost zero. So
వాళ్ళకి
the,
దాని గురించి కాదు కానీ ఒక పేషెంట్ హస్బెండ్ చనిపోయాడు అని
I think
చెప్పేసి
somebody has to
వాళ్ళ
mute.
పేషెంట్ అటెండర్ 5 మంది ముస్లిం
Please,
పేషెంట్ చుట్టూ
I
లాస్ట్
request
బెడ్
all the
చూడండి ఎంఐసీలో
participants
మేము
to
కూర్చున్న
mute
రోలో
themselves.
లాస్ట్ బెడ్
Dr. Anand, can you
మాది
help
నిన్న
us to do
ఎమర్జెన్సీ
that?
నైట్ పెట్టిండంట తనే తీసుకొచ్చిండంట బ్రెయిన్ స్ట్రోక్ వచ్చి
You,
చనిపోయిందంట
Request everyone to mute, please.
Right. Thank you. So here you can see in Dillner's study, with 90% coverage, the risk of the women having HPV 16 and 18 is almost zero. You can see it is even below 0.1. That means the relative risk is almost zero as compared to unvaccinated women. On the other hand, Dillner's study that earlier
చాలా అయినాయి
reported
అనుకుంటా సెక్షన్స్
with a low coverage, the risk is almost as same as in unvaccinated. I don't know. Is it possible to tell her to mute? I'm not sure.
బాగానే బిజీ ఉన్నాయి ఈ రోజు నిన్న మొన్న మాకేం లేకుండే
I'll request everyone to kindly mute.
బిజీ ఉంది మేడం మేము అదే అనుకున్నాం అక్కడ వాటిలలో కూడా ఈ రోజు ఎక్టిక్ గానే ఉంది
Dr. Tejaswini, please mute yourself.
Thank you.
అన్ని సాఫీగానే అవుతున్నాయి
Can
ఇప్పుడు
you
సెక్షన్
mute,
అన్నారు ఒక సిస్టర్ వాళ్ళ కేసు వాళ్ళ ఏ సిస్టర్ ఉండేది
the organizer
అనిత
can mute?
సిస్టర్ అని వాళ్ళ పేషెంట్ ఫిఫ్త్ కి రావడానికి I think you mute
Dr.
everyone.
Anand, can you do it at your end?
Ma'am, the host can mute, no? The host can mute everyone.
Uh,
Dr. Aruna, can you mute
yes,
this?
yes, yeah. Dr. Anand is muting everyone.
Sorry for the disturbance, sir. Sir, Dr. Partha?
He also must have been muted, huh?
Yes, unmute. Okay. Can you hear me?
Sir,
Yeah.
yes, sir, we can hear you.
Yes, sir.
Okay.
Yes, sir.
Thank you. So, yeah. So essentially, what we know is that if the coverage is high, the HPV 16, 18 prevalence is almost zero. So there is a huge protection. On the other hand, if the coverage is low, you can see the dots are almost on this line, which is essentially indicating that there is no benefit to the population. Another important, so here you can see the line is at the level of about 70% coverage, and below that all the studies, they have a very significant reduction in HPV 16 and 18 prevalence, showing that in those cohorts of women the risk of cervical cancer is extremely low. This is again another meta-analysis we did. We looked at the HPV 16 and 18 prevalence by the age at vaccination. If you look at the last study, Kavanagh study from Scotland, you see those women who were vaccinated at the age of 18 years and above, yes, they do have protection, which is significant. But then those who were vaccinated at the age below 15 years, for them the protection again is almost nearly 100% against HPV 16 and 18. So this we have to take into consideration. We also looked at the protection offered against HPV, against CIN2 plus lesions based on the coverage. Again, we saw that coverage is very important as far as CIN2, CIN3 prevalence is concerned. So all these studies, you can see they have coverage about 50% and above, and they have significant reduction, 50% reduction in the risk of CIN2, CIN3. This is all CIN2, CIN3. This is not only CIN2, CIN3 caused by HPV 16 and 18. So there is a significant benefit if there is high coverage, and especially if if the girls are vaccinated below the age of 15 years. And then same thing we are seeing with CIN2 plus reduction with age. Say, for example, the study by Palmer, which showed the protection offers against CIN2, CIN3 by age at vaccination. You see those who are vaccinated at age below 15 years, for them the protection is more than 70 or 80%, quite high protection. Cervical cancer incidence is again a very important outcome that we have to look at. Again, we can see that those who are vaccinated below the age of 20 years or below the age of 19 years, again we see the protection is much stronger as compared to those who are vaccinated at the age above 20 years or above 18 years. So age matters, age at vaccination matters, especially when we are thinking of a full cohort of women in a particular country. With sorry. So with that background, we initiated this the project to come up with a recommendation for Europe. As you can see, Dr. Nija is also a member of that team of experts. 25 experts are working on this. So what did the experts did first? The experts first identified what question they need to answer. So the question is, for the vaccinated population, what is the optimal age to start? What is the optimal age to stop screening? And what is the interval for HPV detection based screening? And this is, we followed a very a very stringent methodology called grade methodology, and we have to identify for each healthcare question a PICO, which is called population intervention comparison and outcome. I'll come to that in my next slide. So what we looked at was that which population are we considering? We are considering asymptomatic population. As you know, women who are coming for screening, they are essentially asymptomatic and healthy. But in countries, there may be quite variable coverage from 50 to 100%. Say, for example, in France, coverage is even less than 50%. So we need to consider that. The vaccination policies are also different. In some countries, there is gender neutral vaccination. In some countries, there is girls only vaccination. The herd immunity. The herd immunity is the protection offered to the unvaccinated women, because the vaccination causes, it reduces the transmission of infection in the population. So even those who are unvaccinated, they also get protected. But that protection will be there only if there is a high coverage of vaccination. So we need to consider that. And then also it takes some time for the herd immunity to settle in. So those women who are, the first vaccinated cohort, when they are arriving for screening, for them the herd protection will be there, but it will be less. But after 10 years, this herd protection, especially if we can maintain high coverage, will be very high. So this also we have to consider. Then pre-vaccination HPV prevalence. What happens in Europe, say for example in Romania, the screening program is not well organized. So there is a high prevalence of HPV in the general population, just like countries like India where there is no screening. But in some countries like Sweden, the HPV prevalence is low even before vaccination because they have been screening women for many years, and all the HPV infections and the deletions caused by HPV infection are detected and treated. Then what are the different protocols that the countries are following? And then, of course, we need to consider the vaccine they have used. In most European countries now, they are using 9-valent vaccine, but the countries started with a quadrivalent or bivalent vaccine. Now, intervention. Which intervention are we considering that will change in the vaccinated population? We looked at screening with HPV detection test every 10 years, and the starting age could be 25 years. That will require 3 in a lifetime screening. It can be 30 years, which will require 2 lifetime screening. It can be even 35 years, 2 lifetime screening. So we need to address all these questions if we bring in this as a new protocol. And for every intervention, there has to be a comparator. What is the comparator? Comparator is the standard of care, which is, as I said, current recommendation of screening 25 to 65-year women every 5 years with HPV detection test. And when we look at the interventions and then compare it with the comparator, we have to decide on the outcomes. What outcomes we are going to look at? We are going to look at some desirable and some undesirable outcomes. Some of the undesirable outcomes, if you reduce the screening interval, can be increase in cervical cancer incidence, can be incidence in cervical cancer mortality. But what can be the good or beneficial outcomes? If you don't screen women too frequently, there will be reduction in colposcopy referral. There will be reduction in the number of regressive CIN lesions, that means the low-grade lesions. Because if you screen women too early and too frequently, they detect a lot of CIN1, which will never progress. So there is unnecessary treatment. And also very important in terms of screening is that if you screen women less frequently or screen them late, there will be reduction in preterm births. As we know, excisional treatment has increased risk of preterm birth. So there are some desirable effect, there are some undesirable effect. So we need to look at the balance. So when we come up with a recommendation, we need to see if we change from current 5-yearly screening to 10-yearly screening, what will be the anticipated benefits and what will be the anticipated undesirable effects, and where is the balance. And then also we have to look at cost effectiveness, we have to look at acceptability, feasibility. So all these things we looked at before coming up with the recommendation. Now, first problem we encountered was that yes, there are some studies that have looked at vaccinated population, screening of the vaccinated population, what is the screening outcome compared to unvaccinated. But when we tried to do a systematic review, we found they are very heterogeneous. Small studies, population is very different, interventions are different. So we could not come up with a systematic review that will answer all the questions that we need to address. So what we had to depend on was a modeling exercise. Modeling exercise is more like a mathematical formula that is based on natural history of the disease. Say, for example, if there are 100 women, we know that there will be 10 women who will be HPV positive. Among those 10 women, one may have CIN2, CIN3, which out of them 50% will progress, 50% will not progress. So all these things are put in a mathematical model, and then we come out with all the answers related to the outcomes, desirable and undesirable outcomes, as I showed you before. So this is a very busy slide, don't try to read this, but essentially what I'm trying to tell you is that when you do modeling, you have to take some assumptions to put in the formula. Say, for example, we took vaccine efficacy as 95%. That is, somebody may argue, why not 90%? They say, why not 85%? We got the 95% value as the best value for the vaccine efficacy. Same thing is in terms of screening test performance. In terms of screening adherence, we took 100% adherence. We took CIN lesion treatment possibility as, if there's a screening program, there will be 95% CIN lesions will be treated, 100% cancers will be treated. So that we get the best picture. if you get the best picture, what will be the best benefit or the worst undesirable effect? From there, you can say, okay, now if I reduce it, if my compliance to screening is 50%, then how things will change. So we started with the best scenario and then we went down as we did the modeling exercise. Now, here comes the judgment based on which the working group of experts they had to make the decisions. As I said, the desirable effects first. This is showing the desirable effects. So what will happen with the 10 yearly screening starting at 25 years? As I told you before, this will require thrice in a lifetime screening. So obviously that apparently that is beneficial, but here we have actual value, right? So what will be the benefit if we move from 5 yearly screening starting at 25 years to 10 yearly screening? So the desirable effects of that, the experts consider this as a small desirable benefit because there will be less regressive lesions treated, 63 less CIN lesions treated per 100,000 women screened. There will be lower preterm birth, 4.7 per 100,000 women screened, and there will be 376 less colposcopy referrals per 100,000 women screened. You can also understand that this is not a huge benefit. So the experts said, no, this is a small benefit if we move towards the 25-year, starting at 25-year and 10-yearly interval. Now, the second option is 10 yearly interval, 10 yearly screening starting as 30 years. There the benefits are 428 less regressive lesions treated per 100,000 women screened. Preterm birth is 43 fewer per 100,000 women screened, and the colposcopy referral is significantly lower, 1,219 less referral per 100,000 screen. So the experts considered this as a moderate benefit. And similarly, with 10 yearly screening starting at 35 years, the benefit is larger because there is less regressive CI lesion treated, lower preterm birth, and significantly lower colposcopy referral. So these are the benefits. Now, what can be the undesirable effects? The undesirable effect is incidence of cervical cancer may go up because you are not screening women too frequently. Say, for example, with 10 yearly interval, 25 year, starting at 25 years, there will be 0.02 more cervical cancer per 100,000 person years or per 100,000 women. You can well understand this is very trivial increase, almost like no increase in cervical cancer incidence. Same thing with cervical cancer death or life years lost. So if you screen women 10 yearly, starting at 25 years, the undesirable effect is trivial. If you screen women starting at 30 years and every 10 years, again, the increased cervical cancer incidence is 0.37 per 100,000 person years. Average, remember, in Europe, the average average incidence of cervical cancer is around 9 per 100,000. So if you compare that, 0.37 increase is very trivial. Same, the deaths 0.03 is trivial, increased life year lost is trivial. But when we go to the next one, 10-year interval starting at the age of 35 years, there is increase by 1.2 per 100,000 years. So if the screening incidence, if cervical cancer incidence increases, say for example in Sweden from 6 to 7, they will be very concerned. So this one, the experts, they consider this as a small increase, but in terms of absolute number, for some of the countries, it is concerning. So now you have the benefits, you have the desirable effects, you have the undesirable effects. Now we put this in this format. Now look at what is the net balance. So 10 yearly screening starting at 25 years, there is small desirable effect and trivial undesirable effect. But even better than this will be 10-year interval starting at 30 years. So our evidence shows that there is moderate desirable effect and the undesirable effect is trivial. So the net benefit is moderate, net desirable. For 10 yearly interval starting at 35 years, again, as I said, it is moderate net desirable effect. But then the European experts, they thought that for their countries, they will face a lot of criticism if the screening incidence goes up by 1 or 1.5 per 100,000. So it is their perception. So this is nothing written in on stone. This is something that the experts considered, but then based on herd evidence coming from the modeling studies. We also looked at resource saving. Obviously, you can well understand if you screen women less frequently, there will be large savings. The less is the frequency of screening, or you delay the screening, there will be more saving. And of course, we found all these three interventions as very cost effective for European context. So with certainty or moderate certainty of evidence, we know that these interventions can be cost effective. Now, based on these, also we need to consider the real scenario in Europe. Say, for example, in average European countries, say, for example, in Belgium or in Austria, the pre-vaccination HPV prevalence is low, yes. Remember, in Europe, the vaccination coverage is not that great. In Germany, it is less than 50%. In France, it is less than 50%. But on an average, in most countries, it is between 50 to 75% vaccination coverage. So this is considered as the current European setting. But then there can be some setting like Sweden where the pre-vaccination HPV prevalence is low, vaccine coverage is at 90%, and they are at a very good situation, and Romania is at a worse situation. So when we are coming up with recommendation for Europe, we have to consider all these things. So the experts were a little guarded in coming up with their final recommendations. So these are the final recommendations. First thing is European, you can see working group suggests, it's not saying recommends. There is a bit of nuance in the wording. So when your only evidence base is modeling study, you cannot have high certainty of evidence. Modeling is not high certainty of evidence. It is low certainty of evidence. So that is why it is a suggestion, not a recommendation, because we don't have enough evidence. So, and then this is essentially for those birth cohorts who were vaccinated before 15 years of age and entering screening for the first time, right? Things will change as time goes. So if the vaccination coverage is at least 75%, in that case, irrespective of pre-vaccination HPV-16 prevalence, start screening at the age of 30 years and at an interval of 10 years between negative HPV tests. This is very significant change in European context because even now they screen women with HPV test every 3 years in many countries. So the recommendation is to go for 10 yearly screening starting as 30 years if the coverage is more than 75%. If the coverage is 50 to 74%, and if the pre-vaccination HPV-16 prevalence in the population is low, then again you can start screening at the age of 30 years and have an interval between screening at 10 years. But if the screening coverage is 50 to 74%, vaccination coverage is 50 to 74%, and the pre-vaccination HPV prevalence in the population is high, then you cannot start at 30 years. You have to start earlier at the age of 25 years, but you can still go for 10 yearly screening. But if a country has HPV vaccination coverage below 50% in a birth cohort, irrespective of pre-vaccination HPV prevalence or anything, you have to continue screening just as you are doing currently. So every 25, starting at 25 years and every 5 years, the women need to be screened with HPV test. Now, so this is the kind of summary of the recommendations. So as I said, this is the recommendation for women who were vaccinated at age below 15 years. Those who are vaccinated at age above 15 years, they need to be screened exactly as it is for unvaccinated women. And then, based on screening coverage, you look at the HPV prevalence pre-vaccination. If the screening coverage, sorry, if the vaccination coverage is less than 50%, forget about everything, continue screening as you do. If the vaccination coverage is 50 to 74%, then look at your pre-vaccination HPV prevalence, and based on that, either starting at 25 years or at 30 years, screen every 10 years. But if the vaccination coverage is more than 75%, you don't have to look at anything else. Start screening at 30 years and screen every 10 years. Now, what is the relevance of this in Indian context? In Indian context, obviously, we don't have any program, right? So, and then even if we have a program in a year or so, those the women who are vaccinated in a program, it is we still have to wait for 15 years to think about them. But we have women who are for whom we know that she received the vaccine below 15 years of age. So for them, the last recommendation is most applicable, because if we know certainly that a woman has been vaccinated, then for them we go for the safest, the most cost saving option. Start at the age of 30 years, or if you remember, even if you start at 35 years, there is considerable benefit and very trivial increase in incidence of cervical cancer or mortality. So you can even start at the age of 35 years and screen every 10 years. So for an Indian woman who has been vaccinated, known to be vaccinated, she can be screened once at the age of 30 years or 35 years, repeat screening after 10 years, and after that, if she is still HPV negative, forget about any further screening. So that is the take from this European exercise for the Indian population. So I'll stop here and I'll be happy to take questions. Thank you.
Sir, I would like to say something. Lata here. Good evening, sir.
Hello, good evening.
So, very nice presentation. Actually, we should not have any doubts. But as you said, the age, those who have received vaccination, and that's a very small number still in our country. And I think if you look at the screening also, no one starts at the age of 25, or even having even one method of screening still is very, very, I think, primitive in our country. So if a person who is not vaccinated, should we really start screening at 25? And that too, HPV screening, I think, I don't know, most of the centers, at least in a government setup, is still not being done. So should we continue with
for Indian setting, the WHO recommendation is the most appropriate. So if you and then also the Foxy recommendation is there. Sorry. And the Foxy recommendation is also there to start screening at the age of 30 years. And with HPV detection test, depending on the resources available, every 5 years or every 10 years, you need to screen. So at the present moment, as I said, in India, we still have to wait for quite a few years before we start thinking about population level decision. Having said that, Sikkim introduced their vaccination program in 2018. So, but then still, even for them, the upper age was 14 years. So you can understand those 14-year-old girl will take, not before 2032 or 33, they will be eligible for screening. So in India, we need to consider at individual level, if somebody is vaccinated, I know that she has been vaccinated. For her, I can start at the age of 30 years, or even I can start at the age of 35 years, two rounds of screening, negative HPV test, no further screening to be done.
That's really ideal, sir. But what about cytology? I mean, in places where people are still continuing, because HPV is not really available in government institutes, and cytology is sort of available. If that is there, should we still continue with 3 years, though we try to implement, or should we do away with it?
It's not a question of doing away with cytology or even with VIA. We need to, we need to screen the women, even those who are vaccinated. So if you have VIA or cytology-based screening, obviously you can, again, the basic principle remains same, because they are vaccinated, their risk is so much lower. I mean, don't screen them too frequently. Even if
Yeah.
you are using VIA or cytology, just start the screening at the age of 30 years or 35 years if she is a negative. But then cytology VIA you can repeat after 5 years. And then if she
Yes,
is
five
negative for
years.
two years, then she has already reached 45 years of age. And after
Sure.
that, there is very little risk of getting new infection, which will progress to cervical cancer.
Yes, sir. Thank you. So there is a question in the chat box. What is this data in relation to? What OS the standard this data comparing to?
Uh, Sorry.
I think this was about that, you told us, so less more than 75% vaccinated or population vaccinated.
uh,
You start screening at the age of 35
so,
years in one.
what OS the standard this data is?
So this was my
Sorry.
question. I'll
Yes,
I'll
yes, please.
ask
Yeah,
this.
yeah, please.
So
Yeah.
you were said compared to something, the rate was this much more or this much less.
Yes.
Compared to what was the standard you were
Yes,
using?
as I showed in my slide, the comparison was current standard of care in Europe, which is screening starting at the age of 25 years and every 5 yearly screening. So
Got it.
compared
Got
to
it.
that, if you increase the interval to 10 years and start screening at the age of 30 years, there will be less colposcopy referral, less treatment of non-progressive CIN lesion, less risk of preterm birth.
Thank you for clarifying that.
I think the sir things are looks very clear to us. India is in a no stage. We have a vaccination rate is around 1% and a screening rate is around 3%. I think your tip is that you should individualize this. The girls who have been given vaccination by the age 15 years, we can start screening them at 35 and not earlier than that.
Yes.
But the people who have been not vaccinated, millions and millions of
30 years.
those, I think we have to start screening it definitely at 30 years.
Yes, exactly.
Actually,
That's
sir,
Whatever
follows
is
WHO
available to
recommendation.
us.
if we do this HPV screening itself, because it's 10 years, so cost will actually come down rather than doing this cytology and, that
Yes.
I think somehow we have to reinforce to the government that this becomes mandatory so that the cost is come down and the treatment cost also will come down.
Madam,
And
I
now
think
we
the
have
bill
the
is not
Indian
there among the bill is
test.
not there among the gynecologists to screen. Otherwise, why it should stick around 3% as for the pan India
Yeah.
incidence is concerned?
Yeah.
Dr. Sarita, can we have your comment, please?
Yes. Hi,
Sarita.
Partha. Yes, it was a very interesting study, and I think it will be really good to know. Yes, I mean, what was the HPV? What HPV prevalence do you consider as low or high?
Very good question, Sarita. So we looked at the HPV prevalence in Europe, which in HPV 16 prevalence. We looked at HPV 16 prevalence in women who had normal cytology. So in apparently normal women before the introduction of the vaccine or the vaccine era. Say, for example, in India, we also have similar data. So we looked at if the incidence, if the prevalence of HPV 16 is less than 6, then it is considered as low prevalence. And then I forgot exactly what was the high this thing, but then so there are three categories: low, medium, and high. But if it is below 6%, then it is low.
So at what age are you considering this prevalence?
It is again, it is in the general population of women. So this is from the studies that have looked at HPV prevalence in the population. Most of the studies they have looked at starting at the age of 25 years. So more, so 25 to 30 or 25 to 35, that is the age of prevalence. Yeah.
And again, in India also the population, the prevalence varies in the populations actually.
Yeah.
In the hospital-based populations, the prevalence is higher in the
So
general.
this is population-based prevalence studies. So in India also we have some of the good population-based prevalence studies. If I remember, there is one from there are studies in Chennai. Dr. Nija did studies in the general population, and our current HPV vaccine study also has very good data over a long time. What is the HPV prevalence in the young women?
Right. The other question I had was this all these studies must be I mean they probably had use the Gardasil vaccine. Now we with the Cervavac, since a lot of the girls now are getting Cervavac in India. So did we have data about Cervavac and what um
Yeah.
how did-
No, the studies, first thing is, as I said, we based on modeling, right? Our whole exercise was based on modeling. In the modeling, we put in the protection offered by 9-valent vaccine, protection offered by Cervarix, protection offered by Gardasil. All of them were considered. And as you know, it's essentially the protection against 16 and 18 is same across all the different types. But then 9-valent vaccine has some additional protection. So we consider all the different types of vaccine. Sarvavac, essentially, it is a bivalent, it's a quadrivalent vaccine, but protecting against HPV 16 and 18. So it should not be any different from Gardasil.
So
Right. Okay.
I have one more doubt. So all these studies were done with the 2 doses, right? Before 15 years and not a single dose vaccine.
Exactly. That's
Yes, so we considered what we considered was now if you look at our Indian data, the Indian study which looked at single dose compared to 2 doses and 3 doses, there's absolutely no difference. And I don't know whether you know about a very large randomized controlled trial, the
Yes, which
Escudo
going
trial
on.
yes.
done in Costa Rica came out with their results last month. And exactly as we have seen, more than 90% vaccine efficacy against HPV 16 persistent infection for 1 dose and 2 doses. So there is no difference. So
And
we just looked at HPV vaccine this thing at 95%.
so can we consider the upper age limit as 20 years as is being recommended now, or should it be at 15 for single dose?
As I use and now there is this thing. Okay, you have seen the best of results, right?
Yeah.
So say for example, if your vaccine efficacy is a little lower, what will happen? Obviously, you will get from 0.03 per 100,000, you may get 1 per 100,000, extra cervical cancer, which is again from Indian context, where we have 14 per 100,000 as the incidence. It is quite trivial. So really does not matter much.
So
Thank you.
have some countries shifted to change their screening program? The guide their own recommendations in countries have they changed the countries who are actually vaccinating the
Yes.
population?
So, Saita, already Netherlands, yeah, Italy,
Uncle Atwood today, Anna
Australia,
Anand.
they have already changed their screening
Radhe Tedani,
recommendation.
where it's
So these are the
computer.
three. UK will very soon
Karan?
change their screening recommendation for the vaccinated course. Yes. And after
Right.
this European this thing is published, so this becomes a kind of general recommendation for all European Union countries. So they will all gradually change.
Right. That's interesting. Yes.
Thank
Sir,
you so much,
vaccine
sir. Can we wind up this talk? And sir, if you can
start
please,
chitta
I request
తాతయ్య
that if you
చిన్నాన్న
can just reply in the
ఎందుకు మాట
chat box
మార్చి
to the other
ఏంటి
questions which are there.
అంటే నేను వదిన
Thank you.
కంటిన్యూ
Thank you so much.
చేస్తానమాట
Can I ask one question,
అంటే
ma'am?
కూడా ఆల్మోస్ట్ అక్కడే తింటదండి నాకు అలా నలుగురు కొడుకో
Can we?
Yes, thank you, sir. And Dr. Sharda ma'am, your point definitely taken. Now with these weekly webinars, we as a general gynecologist, we also get a push to screen and to vaccinate women more so that we also come into that category of low prevalence and highly vaccinated population. So next we come with the panel discussion on managing women with positive HPV test. I would like to request the moderators, Dr. Shweta Bilani. Ma'am is our senior consultant at Sun Permanent Hospital, and she is vice president of IHCCP. And Dr. Payal Agarwal, she is also consultant at Sun Permanent Hospital, and she is the treasurer of DGF Civil Lines. Ma'am, I request you to please start the panel discussion.
Thank you, Anju, and thank you, Dr. Partha, for such a mesmerizing talk. It was really a great learning. And moving on to the application of this HPV test, which we are facing day in and day out, coming on to the panel discussion, which is on managing women with HPV, positive HPV test. Is my screen visible?
Yes,
Yes,
ma'am, it is
madam. Yes.
visible.
Dr. Shweta, do full screen.
Yeah, I'm trying to do that actually. Yeah. Okay. So, discovery that persistent high risk HPV is a uh, causative organism for the development of lower genital tract cancer. There is a paradigm shift, and WHO IARC recommends HPV DNA testing as a primary screening test. And if we talk about the guidelines and the researchers, we all know that if there is an HPV positive, there is either other high risk positive, in which will need a triage with VIA or cytology. And if it is an HPV 16 or 18 positive, we will require a colposcopy, whatever the triage says. So we have esteemed panelists with us today, Dr. Leela Digumati. To save the time, I'm just giving a one-liner CV, but they are all known to everybody here in the ISCCP family. Dr. Leela Digumati is gynae oncologist at St. Theresa Hospital and Eswin Hospital, Hyderabad, and she is an immediate past president ISCCP. Dr. Smita Joshi, she's a senior scientist, Prayas, Pune. Dr. Bharti Abhyankar, who's a consultant obs-gynae, Purva Hospital, Kolhapur. Dr. Pranay Talwar, professor, laboratory oncology at Dr. B.R. Ambedkar Hospital, AIMS, New Delhi. Dr. Bindya Gupta, who's a professor, Department of Obs-Gynae, UCMS and GTB Hospital, and Dr. Nilanjali Singh, who's an associate professor, Department of Obs-Gynae, AIMS, New Delhi. Welcome all the panelists. So here we go with the first case scenario. This is a 33 years old para 5 L5 came to the OPD for pain abdomen. On routine screening, her LBC was normal and her HPV 16, she's positive. Dr. Leela Digumati, this question is for you. Madam, how will you counsel and manage this woman?
Yeah, good evening, Dr. Sweta and the other panel members. Thank you for making me part of this wonderful panel. So, yeah, you have already shown the first slide, how you need to triage HPV 16 positive. But anyway, with regards to the counseling, so I understand this lady had co-testing. So before actually I start counseling about HPV 16 positivity, I just want to go a step behind and find out what she understood about screening. Usually we need to have a pre-test counseling before because this is something like an opportunistic screening, which you have advised her when she came to OPD with a different problem. So I hope she understood what is the meaning of the screening. If it was not clear, first I would explain a little bit about why she had the screening and other things. Then after that, I'll explain to her the result. The good thing is her cytology has come back normal, but HPV 16 was showing HPV 16 is detected. So now I think we need to use the word the HPV is positive means the HPV virus is detected in the thing. So HPV detection doesn't always mean that they are going to have a cancer. It only slightly increases their risk compared to the general population of developing pre-cancer or cancer. So these things we need to explain to her the way she understands. So that is how we have to talk to her. And each time we need to find out what questions she has, because most of the times these people do a lot of Googling before they come to us. So we need to explain, we need to answer first, get the information, how much she understood, if she is educated and she has already done some kind of a homework at home. So with this, I think we need to move further about what we are going to do with HPV 16 positivity.
Okay, madam. So how will you manage this case after counseling?
Yeah.
If she agrees and she understands, how will
Yes.
you manage this case, madam?
Usually HPV 16 positive, because we all know this is the HPV 16 and 18 are considered to be the high risk positivity, and with more than 70% associated with cervical precancers. And it is already a partial genotyping. We know the genotype. So best thing would be to triage with colposcopy.
So, madam, these are the pictures of this patient. Can you please throw some light on
Yeah,
these?
yeah. So looking at the first picture, I presume that her colposcopy is adequate.
Hello,
And
madam?
yeah, I think the colposcopy is adequate. I'm able to see the entire cervix here. And coming to the second picture, I understand that it is probably after application of acetic acid because there is a timer. It is under 3 times magnification. But only thing is, this picture is taken after 5 minutes of 40 seconds of application of acetic acid. So it looks like a type 1 teaser to me, and at probably at 12 o'clock, I'm able to see some kind of a faint aceto white with diffuse borders. In the lower part, I'm not sure whether it is part of the columnar epithelium or a kind of a breach. I'm not very sure about it. Uh, and then this is the estovite I'm able to see, and I'm not very sure about this part, whether it is normal or only this part is the abnormal part. And I don't have any iodine picture. I'm not seeing any abnormal vessels, or I'm not seeing any mosaics or punctations. It appears to be a low grade lesion, and I don't have an iodine picture. But looking at the sweet score, I I think it should come around. Excluding the iodine, it should come around 4.
Thank you, ma'am. There was an atypical vessel, if you can see here, at around 7 o'clock position.
Okay, yeah, okay, maybe yes. I'm
Okay.
not sure. I'm not very sure about this. Yeah, okay.
So this biopsy was done for her. We took a punch biopsy from the 12 o'clock position and 7 o'clock position, and the report came out to be as CIN1. Dr. Bharti, can you please help us to manage and follow up this case with CIN1?
Yes, thank you very much, Dr. Sweta, for giving me the opportunity.
As Dr.
And
Bharti.
hello, am I audible?
Yes,
Yes,
ma'am, you are.
you're audible. Okay. So usually these CIN1 patients, we already have taken her biopsy, and this is a CIN1 means low grade type of lesions. So low grade type of lesions will need only follow reassurance to the patient that she should come after 1 year for rescreening. We will like to screen her after 1 year by HPV testing because she's HPV 16 positive. And we can advise her vaccination definitely, but not as a therapeutic vaccine for her. And we must counsel her for that also. So if the patient is very much sure that you are sure that patient is going to come for follow-up, then it's okay. But if the patient is not able to come for follow-up, then it's better to advise her treatment also.
Thank you, ma'am. Thank you. Moving on to the second case, I would request Dr. Payal to take up this case. Dr. Payal, please.
Good evening, everyone. So coming to the second case, we have a 51-year-old lady coming to the OPD. She is para 4 life 4 with diabetes. She has come for a routine checkup. Her cervical screening was done as a routine screening and her LBC was normal, but her HPV testing showed 16 positive. So her colposcopy was done in view of HPV 16 positive. Dr. Bindya, ma'am, would you throw some light on the colposcopy and vaginal findings?
Yeah, good evening, everyone. Thank you, Dr. Shweta, for making a part of the panel. So in this, as you can see, the colposcopy is adequate. We can see the whole cervix, but I'm not very clearly able to see the entire transformation zone. Maybe it's a type 2 because we cannot see the the upper limit of the lesion. Some diffuse acetoide uptake is seen at around 6 o'clock in this image, and also in the vagina we can see some acidoid areas like typical papillomatosis of the HPV. Some those areas are seen in the vagina, posterior vagina, and they also have taken negative for Lugol's also. So it is there definitely findings are there in this colposcopy image. So I'd like to go for some biopsy because she is HPV 16 positive with some findings on the biopsy. So first, we should biopsy both the vaginal lesion also as well as the cervical part.
Yes, ma'am. So her four-quadrant punch biopsy was done in view of HPV 16 positive, which showed chronic cervicitis, and endocervical biopsy was also taken, which was also normal. The vaginal wall biopsy also showed chronic inflammatory infiltrate. There was no signs of any malignancy. 1 year later, the patient came with irregular bleeding. Her repeat HPV was done and it showed other high risk positive. On TVS, we showed the anterior wall fibroid, and a hysteroscopy was done in view of irregular bleeding. The DNC was also done, and the histopathology report showed a non-secretory endometrium. Patient continued to have menorrhagia, so her hysterectomy was done. On histopathology, uterus showed adenomyosis. Dr. Smita Joshi, ma'am, the question is for you. How will you follow up this patient after her hysterectomy?
Yeah, so thank you for that question. I think this patient was initially HPV 16 positive, and then subsequently after hysterectomy, she is other high risk positive, and she is also diabetic. And her initial investigations, including the endocervical curettage, were normal,
Normal.
but she also had some vaginal lesions, and so she needs to be followed up subsequently, at least with HPV from the vault and cytology as well, and also the vault examination initially after a year, and then depending upon the report that we get after 1 year of the hysterectomy.
So for how many years do we need to do the HPV testing, ma'am, if she is negative in the subsequent year?
If she is negative, then we can repeat it after 5 years. So continue that screening at least for 20 years following the initial report. We also have to find out which test was used initially, which showed HPV 16 positivity, and then subsequently it was other high risk, and she is diabetic. So whether that that she had that transient kind of a infection initially, and then again the high risk infection. So we need to consider her history of diabetes as well, and continue to screen her as if she was, she was she was anyway HPV 16 positive initially.
And both times it was real-time PCR. That was the test for our HPV. That was the mortality.
Dr. Payal, in this, what was we said adenomyosis on histopathology? What did they comment on the cervix? Sorry to just interrupt.
It was chronic cervicitis.
Okay, again in the final histopathology also showed.
Yes, ma'am. It was chronic cervicitis.
Okay. So maybe we should follow our vaginal lesions very, very carefully, because although you've done a vaginal hysterectomy, as ma'am said, we have to be very careful with the vault examination and the smear.
Okay.
And HPV.
Okay, thank you, ma'am.
Dr. Smita, this question I really wanted to know, like she was HPV positive first time and then other high risk. How will you consider this? Will you consider as a persistent infection, though the genotype is different in both the cases?
Yeah, so we really do not know whether it was a new infection subsequently, whether there is any change in partner, or because of her diabetes, she is not able to, the normal clearance is not there. And the HPV test that is used at both the instances. So it is also important which test, which lab did the test. So those things.
So the test was done in the same lab
In the
both the
same lab.
times.
Okay. Yeah. So it is possible that someone was HPV 16 positive, and then subsequently she had other high risk positive. So it was probably missed in the first test. So if you follow these women over a large, for a long duration, it is possible to see, new HPV genotypes in women
even in the older group, although more common in the younger generation because of new partners and all the behavioral issues. But it is possible even in the older age group as well.
Thank you, ma'am. Thank you. So moving on to the third case,
Madam,
she
just
is
to
a
be
nulli.
if the HPV-16 remains positive after 1 year, Wald smear shows HPV-16 positive, what will be the management?
So cytology should also be done subsequently, and then look at the vault again after 1 year if HPV-16 is positive. And depending upon the cytology and your colposcopy, you can manage the case accordingly.
Vaginal colposcopy is very important in this case, and also so both the vulvoscopy and vaginoscopy is important because she already had vaginal lesions. So we have to be very careful and look at are we missing a vein or something, because we haven't done a vaginal the biopsies.
At that time, biopsy was done, Dr. Bindia, and it
Biopsy
was
was
just
done.
chronic
Yeah,
vaginnitis.
biopsy was normal, I think, that time.
At the time of
Biopsy was normal.
hysterectomy, no
Positive.
vaginal. Yeah.
No, I'm saying after 60, after 1 year, ma'am is saying that 16 is positive. In that case, again, we have to do a vaginoscopy and a biopsy.
True. One has to be always on alert for her if she is HPV positive, 16 positive. Then vaginoscopy is a very important thing in this patient and has to be done very carefully. So moving on to the next case, which is similar to this one and in which the vagina and the vulva is involved. Moving on to the third case, she's a nullipara 39 years old patient with chronic vulval itching and white discharge, not relieved on medical treatment. And again, this patient is also HPV 16 positive. Dr. Nilanjali, this case is for you. How will you manage this case?
Right. Thank you, Dr. Shweta, for having me here. And yeah, this is something which definitely requires a colposcopy. She is HPV 16 positive, but apart from that, she's also complaining of vulvar itching. So she needs a good local examination. And after treating her infection, if it's there and if the itching persists, we can go for a vulvoscopy if there's no lesion which is identified to a naked eye on the vulva. And for colposcopy, like the picture shown here, so this picture, it looks like a type 3 transformation zone. I can't see the transformation zone clearly here. So it looks like a type 3 transformation zone. And well, I can't really say that there's an estro-white area anywhere here. Maybe a little bit at 11 o'clock, but I'm not very sure about it. I'm not directly visualizing it, but yeah, I don't know if I can see a white area on the vagina near the gloves. If that is a estro-white area in the vagina, then yes, definitely this is the one which we need to biopsy. And then on vulva, I can see this abnormal area, which is very, very suspicious. And this also needs a biopsy on the third picture. And the fourth picture, again, another lesion. I can see probably a vulvoscopy was done, and another lesion I can see on the near the introitus at the inner margin of probably labia minora at the I would say 5 to 6 o'clock position. So these are definitely very suspicious areas and they need biopsy, and further management will depend on the histopathology report. And then yeah, we have done the vulvoscopies. I guess we have done using acetic acid itself. So
yeah, these pictures are after acetic acid
acetic
application.
acid. So yeah, so they appear as to white and the vulval lesions. Yes.
Thank you, Dr. Nilanjali. So the biopsy was done from the vulva, the most suspicious lesion, and that came out to be vulval carcinoma in situ. And the punch biopsies, the cervix appeared grossly normal. So punch biopsies were taken and all were CIN1. And the vaginal biopsy, as you rightly pointed out, the one which has the aceto-white, it was all aceto-white everywhere. So the biopsy was taken, which came out to be VAN1. So, Dr. Bindia, how will you manage this case?
Yeah, Dr. Shweta, quite a complex now. She, I think, has the typical HPV infection of the entire genital tract, and she is nulliparous. Yeah.
Yes, huh?
So I think for
Yes, yes.
CIN1 and vein, I'll just not do anything for her. But yes, for the carcinoma in situ, which I think is VHSIL, if we see it in the latest terminology, we should go for a wide local excision to just to take the margins and all, and we need to excise the lesion. And even for CIN1 and vein, I think we can watch, because for carcinoma in situ or VHSIL, we have to rule out occult invasion. So I hope, like, we have to rule out whether we are dealing with a microinvasive vulval CA or not. So that is why I would like to prefer to go for a wide local excision for the vulval lesion. So that is one thing. And factors, as you said, in determining the management is the nulliparity. That is why I will not like to disturb the cervix as of now. And her genotyping was what, 16 positive?
Yes, ma'am.
Yes, yes. Yes, Dr.
16
Bindia.
positive. So I think we will repeat the HPV, and we can call her up after like 6 months and repeat the HPV. But again, if suppose you think that she is very worried about that, and although I also could not make out the transformation zone very clearly on the colposcopy, but if it is a T1 TZ, we can even offer her ablation if she is willing for that, because that will not hamper with the fertility. And vaccination, definitely we can offer her, because as Dr. Bharti had said in the previous the case also, that this is a prophylactic vaccine and not a therapeutic vaccine, but it will help in reducing the recurrences with the vaccine genotypes. So it will help to reduce the risk of recurrence with CIN, and is reduced. But with vein and VIN, we don't have much of data how much it helps in reducing the risk of recurrence. But with CIN, definitely we have the data which supports that vaccination reduces the risk of recurrence. That is my.
Thank you, Dr. Bindia. But will you biopsy this lesion, which is in the fourth picture? This lesion,
Which
the
region?
vestibular lesion
Yeah.
here,
You've said CIN1 already, na, in the
Dr.
biopsy?
Bindia.
Yeah, I'm there only. You've said CIN1 in the biopsy?
Actually, her cervix looks, it looks like type 3 TZ here.
Yeah.
And I'm not sure from
Dr.
where you
Bindia, this one, will you take biopsy from this lesion, which is on picture fourth picture?
Yeah, definitely. Because that is
I
also.
did not take because I thought that's a what?
No, I think since that was a almost similar looking lesion in the inner ring of the vulva, which is there in that CA in situ, which you said the lesion. So in that case, I would definitely do a key sponge. At the same time, we'll be biopsying both the lesion, and if both the lesions they come out as VHSIL, I will offer her a wide local excision rather than doing medical management in this case, because we have to note occult invasion. This is the vulvoscopy, and you have the lesion in the middle and the inner ring, so they are both ominous.
Dr.
Okay,
Shweta,
thank you very
about
much.
the
Thank you.
cervix, hello, can I just
Yes.
comment on the previous slide? So
May I
it
know
looks like
who's there?
I'm Smita Joshi speaking.
Smita ma'am is saying.
Yeah.
Okay, okay, Dr. Smita. Sorry.
So
Yes, ma'am.
it looks like type 3 TZ there. So I'm not sure from where you took the cervical biopsy, and ECC might have been more useful than the
No, ma'am, the
cervical biopsy.
ECC was done in this case and it was normal.
Okay.
So, Dr. Shweta, this was a type 3 TZ or?
It was a type 2. It was type 2, but just because she was HPV 16, so ECC was done.
Okay.
Dr. Sweta, where
was
did you
normal.
take the vaginal biopsy from? Because these pictures, as Dr. Bindia pointed out, we are seeing a lesion here.
So,
and
ma'am, the biopsy was taken from here. The acetowhite area, it was just a random biopsy which was done from the acetowhite area.
The vagina.
Okay.
Yes.
Shweta, I'm sorry, I'm not the panelist, but how was these lesions? Miss, they look quite big actually.
I think the key sponge was done for the vulval lesion, and that came out as
Yes.
we had
I didn't get you, Bindia. What was done?
I think the key sponge biopsy was done, na, Dr.
Okay.
Shweta?
No,
So,
because she said on
Yes, yes.
valvoscopy they found this. That's why I was
yeah, in the
wondering.
No, the
valvoscopy, they did a
biopsy is
key
being
sponge
done.
directed
No,
biopsy.
biopsy is done. I'm saying naked eye, these lesions should not be missed, right? Maybe because it's in the fold they missed it.
No, they
But
must have.
it's not being missed, ma'am.
We
And
mistook
moreover,
them
when
as
they
Ma'am, it
spots.
is, I think, not missed. They have accentuated the
Okay.
lesion on valvoscopy.
Okay,
It was
okay,
already
okay.
there, but I think with valvoscopy, it got more accentuated,
Okay,
and the
okay.
other lesion must have appeared on valvoscopy. So
Okay,
it has
okay.
not been missed. It is, I
No,
think they
I'm not
want.
talking about the vaginal. I'm talking about the vulval.
Yeah, even the vulva also, I think it got
Okay.
accentuated on the
this
valvoscopy. In
Okay.
patient
fact, it became
typically has
multifocal.
multifocal lesions
Yeah,
Okay, okay.
multifocal.
everywhere. There are a lot of more
Yeah.
lesions which we saw now, but
Okay.
the worst were biopsied.
Okay, okay. Fine, fine. Thank you.
Okay. Dr. Payal, can you take up this fourth case?
Yeah, coming to the fourth case, this is a 38-year-old female who came for an infertility workup. Her cervical screening was done as a routine test, and her those were normal. In her ignorance, she got her test repeated from another lab, and which showed report of HPV 16 positive. So she came to us. She came back to us. These are the. Can we go to the previous slide? So these were her reports. On the first two reports were from our hospital. The first report, and then the lab people, they cross-checked it from a lab in Hyderabad. That also showed HPV negative. And this is the report of outside lab which showed HPV 16 positive. So, Dr. Pranay, sir, this is a question for you. What are the possible causes of this discrepancy, and what are the criteria for choosing a particular HPV DNA assay?
So thank you, Dr. Shweta, for involving me over here. So we are dealing with the case where we have one, it was positive, then it came out negative, then it is coming out positive outside. So the common causes in our lab setting when we see it is always the cross contamination from the other samples. So sample handlings are really important, especially in a setting where the test is involved in the clinical decision. And then it's coming out again the negative in the other lab. And for the other lab, we can say if we theoretically discuss the possibility if something was positive earlier coming out negative now, probably the patient is now clearing off the viral load or improving. And if it is well, like a transient infection,
So, Pranay, this is actually in the same day the samples are being collected.
same days.
Same day.
Same day. Okay. So then I would put this more towards the laboratory things because, and then different depending on the test. If the test both in the both setting, it was like real-time PCR based testing only. And then afterward, the test came out positive outside also. Is that so?
Yes, sir. So
Yes,
it
sir.
was, she got it done from an outside lab which showed 16 positive.
Mhm. So the theoretical causes can be many, but if we go by the protocol, most of the time the positivity or cross reactivity is one of the major reason in a lab coming out positive. But the negative test, it's difficult to explain if the sample testing was on the same day and on the same day, and did you like split the sample sometime? Clinicians sometimes split the sample. They send some sample,
No,
half of
sir.
the
No, sir.
sample.
It wasn't split, sir. We had sent a sample, and
Okay.
it came out to be negative. The patient got it done, got the sample collected from other lab also,
Hmm, hmm,
from
hmm, hmm.
by some other doctor.
Mm. So many times it is seen that when the load of virus is also very low, the test do not comes out to be positive. So if we go by the testing methodology, what kind of tests being utilized? So most of the tests which are like amplification based tests, they would come out positive even in a small or low viral copy numbers. But when this test is been done outside and it is coming out again positive, then possibly there is a issue in the lab. So many times it also happens that, especially seen in cases when the lesions is actually becoming invasive and the primers which are being utilized are targeting the L1 region of the HPV virus, whereas the virus has integrated into the cell and it is now at that stage where there is development or the production of E6 and E7 oncoprotein, whereas the L1 what we can say the primer is going down. So then also there can be a theoretical possibility is there, but I would still say that in such situation it is most of the time lab, and that's why we should always do quality control of the laboratories, and we should always have the lab which is enrolled in a in NABL accredited lab, or they have their own quality control exam. If I share our experience, we have seen tests coming out positive because the adjacent belt is having very high HPV positive RLUs. So in this case, if we go back to the test which is like HC2 based testing, where if there is certain number of copies are there, then only that virus and the test comes out positive. Coming to the second question, whether the criteria of choosing a particular HPV DNA test, yes, because we have already studied that there is a whole paradigm of HPV infection getting into the basal layer, then proliferating, then integrating into the human DNA. So, women coming to your clinic, the virus can be at any stage, but most of the time we are utilizing HPV DNA based testing because they are more robust. If you go by the DNA and RNA based test, then probably the E6, E7 based mRNA based test would be the best. But in our setting where we have hot and humid climate, preservation of sample, transportation of samples is an important issue which needs to be addressed. So another important aspect for a DNA based test is that many times then the virus is in the episomal form or virus is onto the surface of the cell, it may come out positive. So the gist is that you have to follow up, we have to do sometime colposcopy, you have to do cytology. Then coming the third question is there role of mRNA test? Yes. In such a case, when we were having discrepancy, mRNA-based test would certainly help us out, because despite of the fact that HPV DNA 6 DNA coming out negative or positive, with the mRNA-based test is coming out positive, we can rely and we can presume that probably the woman is having HPV infection, and the viral DNA is integrated into the human cells.
So, Dr. Pranesh, this mRNA test is to be done in the test in the sample which has come out positive for HPV 16, isn't it? Rather than doing in the other two samples?
No,
What is your opinion, sir?
you can do it in any of these samples. You can do it because the principle is different. It would be based on the mRNA, and it would be utilizing the E6, E7 mRNA expression. So the if it is coming out positive, despite of the fact that even if HPV DNA is coming out positive, mRNA can come out negative. You have to understand this. So it can come out negative because probably the virus has not yet integrated into the human DNA.
Okay, okay. And
So,
how about
that would consider more specific mRNA, sir.
Yes, but the thing is that RNA is very temperature sensitive, and it cannot be transported till the time it is there in your body. It is good, but once it is outside your body, it gets degenerated. So the collection of samples and preservation of sample is very meticulous in RNA-based testing.
Okay, sir.
Okay, okay, sir.
I
Thank you,
think
sir.
it is also important to use a validated HPV test for
Yes.
screening purpose. So I'm
Yes.
not sure which platform are you using, but currently what we have is the hybrid capture 2 test or the COBAS HPV test. And
Yes.
I suppose BD Oncolarity is available only at AIMS Varanasi. So we have to be really careful in selecting the test that we are offering for screening purpose, Secondly, I'm not sure if mRNA test is available in India, which is validated. It is the Aptima HPV test.
So,
Yeah, but
for mRNA-based testing, now AIMS Rishikesh, there is a separate, not the pathology, but they have a separate molecular unit. They have procured Aptima, the Panther
okay.
station, so it would be available there
Okay.
now. And we are in process of procuring our Cobas. So these are like validated tests. If something coming out of these platform, we can rely on them.
Dr. Smita, thank you for bringing this point of doing a FDA approved test and doing a HC2 test. But then the cost goes up. And I think most of the labs are doing a PCR based test and it is valid. What I spoke to them was that it is validated but with IVD and the cap. How should we use these tests? Because till now we had no problem. This is the first incidence we had this issue.
I think the cost of Cobas has come down considerably. Even the hybrid capture 2 test cost is around 900 to 1000. So we get either Cobas or HC2 for about 1000 rupees. And I'm not sure how much these labs are charging for the PCR that they are offering. So routinely you can, switch to Cobas or the hybrid capture 2 test. Cobas is now Carcinos is offering it for 950 rupees or something this month, and I think next month as well. So, and they have a very good logistic as well. So we are
Okay.
routinely sending the samples to Carcinos for screening our women.
Thank you, ma'am. Thank you for that update. Thank you so
Yeah, and
much.
Dr. Sweta, actually, as you said, many labs will, because most of the HPV DNA tests are real-time PCR based tests.
Yes.
So
Hmm.
they will say that it is a real-time PCR, but they don't mention the platform what they use.
Yeah,
Is it a
yeah.
Cobas
That
platform
is,
or is
yeah,
it
yeah.
Gene Expert platform
Mm.
or hybrid? They don't mention that because
That is
from
their in-house PCR that is
yes,
developed by the
yes.
lab is being used.
Yeah, they use some primers and do it. So
Yeah.
AMPATH, even we do get referrals for colposcopy, and in that most of the times LBC comes normal and the HPV shows 16, 18 or other high risk types. But the platform, what they use, like as Dr. Smita Joshi mentioned, in Karkino's reports are from Adayar, you get what Cobas platform they have used. Is it 4800, 5800, 680? Like that, they
Hmm.
mention very clearly. So we don't get these kind of information from, I mean, I have not seen that kind of information from AMPATH reports. So I'm not sure what platform they are using it.
But ma'am, irrespective of that Cobas, if it is used irrespective of the platform, if it is a Cobas, it is much more reliable than
Yes,
using any other
yes,
PCR.
yeah,
So
yes,
Cobas is a definitely a this thing reliable test, and it also
yeah,
gives you some genotype information also.
yeah, yeah.
So
Dr.
we
Dr.
Shweta,
travel.
sorry
Vindhya,
to
are you
interrupt.
using Cobas in your hospital?
No, we actually we are doing it in NICPR, and we are using hybrid capture. We send our samples to NICPR, and they are it's a part of the project, and they do it with hybrid capture there.
Okay. Okay.
Dr. Shweta, sorry
So
to
do
interrupt.
you
It is
don't, and for the
8:30.
genotype, what are you doing?
Genotype we are not using, only when it is required. Then we get it out, done it out. We get the partial genotyping done whenever required. Routinely, we are only doing the high risk HPV testing DNA by using hybrid capture. Dr.
Thank
Shweta,
you.
sorry to interrupt. It is 8:30, so we can
Yeah, so we can wind off.
find up.
We can wind off and leave the last case. Thank you, everybody, from the entire ISCCP team for making this webinar a continuously successful sessions. Thank you very much and good night. Thank you, Dr. Partha. I hope you are here.
Yes, and so thank you, Dr. Shweta. It was a very, very great. It was a good webinar. Excellent talk with Dr. Partha and a very interesting panel discussion. So thank you all the esteemed faculty for being a part of this webinar today. Now, Dr. Shweta, you really got the new year with a big bang. We had Dr. Partha giving an excellent talk today. So well start to the ISCCP webinar series for 2026. And thank you so much for taking this initiative and doing it so well.
Thank you.
Can
On
you?
behalf of ISCCP, I thank all the attendees and all the faculty for this webinar today. It is because of you people this series have been successful. We have always had more than 100 participants in each of the webinar series, and so thank you, Dr. Aruna. I think ma'am is there.
Yeah, thank you. Thank you.
Yeah, thank you so much, Dr. Arun. And for next month also, 7th of February, 7 p.m. for 70 minutes, slightly extendable to 80 minutes. We'll all have your attention. And I think we can call this off. And once again, a very happy new year to all the listeners and to all the faculties.
Thank
Thank
you.
you, Dr.
Thank you.
Shweta.
Happy
Thank
New
you,
Year.
everyone.
Thank you.
Thank you.
Thank you, Doctor. Thank
Bye.
you, Dr. Praveen. Thank you. Good night.
Bye. Good night.